Good day, everyone. My name is Rosli. I'm from Kuala Lumpur, Malaysia, and you are in a sponsored session by Braun discussing drug-coated balloons, particularly Paclitaxel and sirolimus, in trying to create evidence before claims. I have no potential conflict of interest. Drug-coated balloon, in particular Paclitaxel-coated balloon, has been in the market since around 2005. There has been a wealth of data to support its use in various subsets. But sirolimus-coated balloon has only been there for about 5 years. The attractiveness is due to the drug, and as we know it, limits eluting stents do much better than Paclitaxel eluting stents. But the data is not as robust. So the question is this a concern in trying to use sirolimus-coated balloon at this point in time without having a wealth of data? The key objectives in this session is for you to join us in a discussion about sirolimus and Paclitaxel DCB, follow dedicated discussion on existing evidence on efficacy and safety for both the DCBs, and share insights about the start of the RESPECT-ISR trial and SCORE registry for the next generation Braun's SeQuent drug-coated balloons. This is the agenda. I'll be facilitating the session, and the chat master is by Professor Bruno Scheller. The experience and Paclitaxel-coated balloons review on evidence and safety. The first presentation is by Professor Raban Jeger, and he is from University Hospital of Basel, Switzerland. Professor Sylvia Otto will then discuss on sirolimus-coated balloon in real life, a start of a large all-comers registry. And I'll be discussing our first-in-man randomized controlled trial with the SeQuent sirolimus-coated balloon in the treatment of DES-ISR. And this will lastly be followed by Professor Bruno Scheller from University Hospital Hamburg, Germany, and he will be discussing on the upcoming RESPECT-ISR US IDE trial, a next-generation Paclitaxel-coated balloon. At the end of this presentation, we'll have a live discussion and Q&A, and I hope you'll be actively participating in trying to give your comments and ask any questions about the session that we're discussing. So without further ado, I will be inviting Professor Jeger to present his talk on the experience with Paclitaxel DCB.
Dear ladies and gentlemen, dear colleagues, my name is Raban Jeger. I'm from the Heart Center of the University Hospital in Basel in Switzerland. And in the next 10 minutes, I will present to you my experiences with Paclitaxel-coated balloons, and I will give you a review on evidence and safety. These are my conflicts of interest. I am the PI of the Basket Small 2 trial. This trial has been supported in part by Braun. There are a couple of really good indications for drug-coated balloons, as you know. The most important indication are the instant restenosis. Instant restenosis have been assessed in various randomized trials and have shown that DCB are a really good alternative to drug-eluting stents in this regard. However, there are other fields where DCB have a good track record. For example, the small vessel disease, where among others the Basket Small 2 trial has been active. And there are other indications like the high bleeding risk and also bifurcations where some data have been accumulated. The mechanism of action of drug-coated balloon is depicted here. You see in cartoon A an instant restenosis of a drug-eluting stent. And in B and C, there is the drug-coated balloon coming in, is inflated, and at the end in cartoon D, there is a nice result. The action of the drug-coated balloon is the following. You see here the balloon surface on top, and on the bottom is the vessel wall with the endothelium. And in between, there is the matrix coating. This is the active drug and the excipient. And the mechanism of action is that there is a fast and homogeneous drug delivery into the vessel wall with the inflation of the balloon. The drug is an antistenotic drug, and there is a matrix. This matrix is responsible for the fast transfer of the drug into the vessel wall. There are mainly two anti-proliferative agents on the market. There is, on one hand side, the sirolimus or the derivatives of the sirolimus, and on the other hand side, the Paclitaxel. Both drugs are used in drug-eluting stents also. And the difference between the two is mainly the absorption time in the tissue. Paclitaxel has a much shorter absorption time. It's sufficient to inflate the balloon for only 30 seconds in order that the drug arrives in the vessel wall. Sirolimus has a longer absorption time. In contrast, sirolimus has some other advantages, as you see here. Sirolimus is only cytostatic, has a larger margin of safety, and has a much stronger antistenotic activity. And in addition to that, the physician reception of sirolimus is much better because of the better results in drug-eluting stents. Paclitaxel has been questioned 2 years ago in a large systemic review and meta-analysis. You see here, this is the Katsanos meta-analysis who has been published 2018. And in this meta-analysis, in the periphery, you see here that after 1 year, DCB versus an alternative treatment had the same results. After 2 years, with only 12 RCTs, so less than 50% of the RCTs, the randomized trials, there was a higher event rate in drug-coated balloons, and at the end, after 5 years, in only 3 of these 28 RCTs, there was a higher event rate in DCBs. You see here the same result, and this result has led to a black box warning of the FDA regarding the use of Paclitaxel-coated balloons in peripheral arterial disease. However, this meta-analysis had some major limitations. In a PCR statement published 2020, they stated that this analysis is subject to major inherent methodological limitations that prevent reliable interpretation of the primary findings. Therefore, this study is questionable. Just to give you a short overview of what we think is happening with Paclitaxel in the organism, I show you this slide from Bruno Scheller. You see here that Paclitaxel in a systemic treatment has an amount of 300 milligrams that is used. This is a treatment for cancer, for example. And the local treatment with drug-coated balloons, this is only an amount of 0.4 milligrams in the coronaries and 5.5 milligrams in the peripheral arteries. And therefore, the therapeutic window is really large with Paclitaxel, although the margin of action is quite small. The same is true for sirolimus, although the therapeutic window is much smaller. And therefore, the thinking that this amount of drug in the organism is toxic is not really objective. So what do we have as real results here in coronary artery disease? You see here that a large meta-analysis in coronary artery disease published last year in more than 4,000 patients in 26 randomized controlled trials shows that all-cause death and cardiac death and myocardial infarction and target lesion revascularization after 1, 2, and 3 years is always beneficial in favor of DCB. part of this data is this data here, the meta-analysis of instant restenosis published within the Daedalus project. You see here that the efficacy of drug-coated balloons is a little bit less than drug-eluting stents. However, the safety is at least similar. You see here that Paclitaxel-coated balloons, they have a really good safety profile in this indication that is at least as good as with drug-eluting stents. And in this cartoon, you see here that on the left side, the balloon, on the right side, the drug-eluting stent. The primary efficacy endpoint was a little bit worse in drug-coated balloons, but all the safety endpoints are in favor of the balloon. Here I show you some long-term results of the Basket Small trial. The Basket Small 2 trial was the largest randomized trial in de novo small vessel disease and compared drug-coated balloons against drug-eluting stents. And you see here after 3 years, there is really a good result regarding efficacy and safety. Cardiac death, myocardial infarction, target vessel revascularization was really similar after this long-term follow-up. This was true after the primary endpoint and is true after 3 years as well. When we look at cardiac death and all-cause death, there are really low results, low rates of these two endpoints, and also similar endpoints for drug-coated balloons and drug-eluting stents. And when we looked at the causes of death within the first 12 months in the Basket Small trial, you see here in this cartoon that we had 25 death cases in the trial. There were 12 sudden or unknown deaths in this trial, and this death could potentially been associated with the implants or the device used. In the two groups, in the DCB groups, there were much more deaths here than in the drug-eluting stent group. But when you look at the really implanted devices or used devices, you see that DS only and DCB only 2 events were occurring, whereas in a group where DCB and stents both were used, there was a death rate of 8 cases. And therefore, it's really questionable whether the drug-coated balloon or the drug-eluting stents is responsible for this. So, ladies and gentlemen, taken together, DCB represent a novel therapeutic strategy in coronary artery disease, and they are established in instant restenosis and de novo small vessel disease. We looked at the mode of action. The two drugs that are used are Paclitaxel and sirolimus, and the body of evidence for Paclitaxel is much larger than for sirolimus, and in large meta-analysis and randomized trials, Paclitaxel had a good efficacy and safety profile. And therefore, there's no signal of increased mortality in patients treated with Paclitaxel-coated balloons in coronary artery disease. Thank you very much for your attention.
Hello and good afternoon from Germany. My name is Sylvia Otto. I'm speaking from the University Hospital of Jena in Germany, and my talk will be about sirolimus-coated balloons in real life, and I will shortly tell you about the recently started SCORE registry. These are my personal disclosures. And the outline for the next few minutes is that I will shortly elaborate on why do we need sirolimus-coated balloons, or do we even need that, give a short overview about the preclinical evidence and the existing clinical studies and the SeQuent SCB study program, and tell you more about the SCORE registry. We all know from large randomized controlled trials from drug-eluting stent that limus drugs or sirolimus is superior to Paclitaxel and drug-eluting stents when it comes to hard clinical endpoints like target lesion failure. And this is why doctors believe that sirolimus might be better than Paclitaxel. The question is if this is the same for drug-coated balloons. We know from pharmacological side that the effects of Paclitaxel are dose-dependent. Paclitaxel leads to an inhibition of smooth muscle cell proliferation, and it also inhibits neointima formation. But on the other hand, it leads to medial necrosis and focal wall hemorrhage, which are disadvantageous vessel wall effects. When you compare Limos versus paclitaxel drugs, we see different effects, cytostatic and cytotoxic effects. Paclitaxel indeed is a cytotoxic drug that interferes with demitosis, whereas sirolimus is a cytostatic drug that interferes with a G1 phase, but here cells remain viable. And due to its cytotoxic properties, paclitaxel has a very narrow therapeutic range, whereas sirolimus has a much larger margin of safety. Both drugs are anti-restenotic, but sirolimus also exerts additional anti-inflammatory effects. However, due to its lipophilic properties, paclitaxel has a fast tissue absorption and a long tissue retention, which makes it so feasible for a long coating. Sirolimus, on the other hand, has only a slow tissue absorption and a short tissue retention. And comparing again sirolimus and paclitaxel, we all know that these are the anti-restenotic drugs that are available for treatment of coronary artery disease in the 21st centuries. Paclitaxel is mainly used on drug-coated balloons, whereas Limos drugs are mainly used on drug-eluting stents. We have a well-described preclinical and clinical evidence for paclitaxel-coated balloons. We have a current Class 1A recommendation from the European Society of Cardiology for in-stent restenosis, and we have a large clinical database including randomized controlled trials and observational studies for indications of in-stent restenosis as well as de novo stenosis. For sirolimus-coated balloons so far, we have a small preclinical and clinical database. So from an engineering perspective, what are the product needs that a drug-coated balloon needs? Ideally, the active substance is lipophilic. We need a drug carrier, and we need to make sure that the drug gets absorbed from the vessel wall during a short contact time. That makes it challenging since sirolimus is less lipophilic compared to paclitaxel, and we need a matrix coating to make sure that sirolimus is getting into the tissue during balloon inflation of 30 to 180 seconds. And it also needs to have a time release mechanism to maintain therapeutic levels over a certain period of time, let's say 2 to 4 weeks. With the SeQuent sirolimus-coated balloons, these requirements were met. The SeQuent sirolimus-coated balloon has a BHT matrix, a butylated hydroxytoluene matrix that controls the release of sirolimus and creates a crystalline sirolimus modification. And we know from preclinical studies that it leads to an immediate drug transfer of 14% within the arterial wall. And after 28 days, we still have 40 to 50% of the initially transferred sirolimus dose in the arterial wall. And when we compare paclitaxel-coated balloons to sirolimus-coated balloons, we know from the preclinical porcine overstretch model that we see similar efficacy, similar reduction of intimal hyperplasia. When we again look at acute tissue concentration in various sirolimus-coated balloons, you see the SeQuent sirolimus-coated balloon not only has the highest acute tissue retention, but also more importantly, the highest retention after 28 days. And this is a short overview about available sirolimus-coated balloons with the indication coronary artery disease. Those are 5 balloons that are on the market. You see the drug concentration varies between the different balloons, and also the delivery agent varies. Only the SeQuent sirolimus-coated balloon has the BHT matrix. Other balloons work with nanoparticles of phospholipids, and you see clinical evidence varies greatly between those products. And frankly, only 2 balloons have sufficient clinical evidence to be used. So the Magic Touch from Concept Medical has a few registry and a randomized controlled trial, and also the SeQuent sirolimus-coated balloon from Braun. When we look at the SeQuent sirolimus-coated balloon study program, we have 2 randomized controlled trials on instant restenosis. One we will hear about later. We have 2 randomized controlled trials for de novo stenosis. We recently started the SCORE registry, and we will have an upcoming larger international trial on de novo and instant restenosis. Lastly, I want to tell you about the SCORE registry. This is a true all-comers registry, a prospective multi-center international study that will take place in Europe as well as Asia. We are planning a sample size of more than 1,300 patients, and we include de novo as well as instant restenosis in stable as well as in ACS patients. The primary outcome variable will be a target lesion failure rate at 12 months as a composite of target vessel MI, cardiac death, or ischemia-driven target lesion revascularization. And we are looking also at various secondary outcomes, including duration and compliance of dual antiplatelet therapy, procedural success, and bleeding complications. We have an international composed support and supervision team. Me, myself, I'm the principal investigator. Dr. Ramsing from the University of Aarhus is serving as a core lab, and we have an internationally composed critical event committee. Right now, we are done with the first patient in. We could include the first patient on April 30th in Jena, and we are currently contracting different sites so that we hopefully will enroll all the patients within the next 2 to 3 years. And this is a short overview about the study centers, as I said, Europe, Asia, and also Saudi Arabia. So I would like to conclude for sirolimus-coated balloons. I think the concept of implant-free PCI of nothing leaving behind is attractive, feasible, and modern. We do have robust, however small, data for efficacy and safety on sirolimus-coated balloon, but we need more evidence. We need randomized controlled trials, especially comparing sirolimus-coated balloons versus modern drug-eluting stents, and also beyond traditional indications like small vessel disease or instant restenosis. We don't know yet how about late lumen enlargement, how the sirolimus-coated balloon acts compared to Paclitaxel-coated balloons, and we still have to set the duration, the optimal duration of dual antiplatelet therapies, and think possibly about the role of new PTY12 inhibitors. And that's my conclusion, and I thank you for your attention, and I'm looking forward to the upcoming discussion.
I would like to share with you the results of the first-in-man randomized controlled trial with SeQuent sirolimus-coated balloon in the treatment of instant restenosis. I don't have any potential conflict of interest. The question that we are discussing all this while is there a role for sirolimus-coated balloon? I think really the challenge is that when you look at the results, and this has been stated by the first 2 speakers, that sirolimus drug-eluting stents in humans have been shown to be clinically superior to Paclitaxel-eluting stents. And therefore, the interest lies to see whether sirolimus drug-coated balloon is as good or better than Paclitaxel DCB. The challenge is really to coat the balloon with sirolimus, allowing enough drug retention to reach the lesion site, adequate drug elution into the tissue, adequate drug tissue concentration in a certain period of time, for example, at 1 month, and this will ensure adequate or appropriate inhibition of new intimal tissue proliferation. The initial study on benchmark was sirolimus-coated balloon catheter was performed by Dr. Clever, and she looked at different crystal modification, either amorphous, crystalline, or mixture of amorphous and crystalline. And this was coated onto the balloon with different agents. And she found that the best was crystalline balloon coated onto a butylated hydroxytoluene, which is the contrast media, at a dose of 4 micrograms per mm squared. In this study of a porcine overstretch model in preclinical work, it has shown that all the drugs were suitable and efficacious in reducing intimal hyperplasia, but the choice was with the 4 micrograms per mm squared onto a crystalline modification. We were very privileged to be given the task of taking up the first in-man study comparing sirolimus DCB versus Paclitaxel DCB in the treatment of DES in-stent restenosis. This was a randomized prospective multicenter non-inferiority analysis study with a control of SeQuent please Paclitaxel DCB with a primary endpoint of late lumen loss at 6 months follow-up. There was also a secondary endpoint of procedural success, MACE, thrombosis rate, and binary restenosis rate. The randomization was 1:1, and we recruited 50 patients with 25 in each arm with a clinical follow-up at 1 month and 12 months and a repeat coronary angiogram at 6 months. I would like to acknowledge the principal investigators for all the study sites in Malaysia. And this was the sirolimus DCB. It was based on the SeQuent neo balloon, the same as Paclitaxel DCB, the size of between 2.5 to 3.5 mm in diameter and length of 15 and 30 mm. The clinical, or rather the key inclusion criteria was we accept DES for 1 or at the most 2 DES ISR, and the lesion length had to be less than 35 mm. We were also able to recruit if there's lesion at the edge of the stents, but not more than 5 mm in length. The key exclusion criteria was fairly standard. And this was a procedural pathway. We prepared the lesion with predilatation with POBA at 0.5 mm, lower or smaller, or at least equivalent to the stent size. We recommended scoring balloon if it's possible, and DCB was only used to deliver the drug and not for lesion preparation. We, of course, make sure that we do not touch the vessel, the balloon, and there's no contact of balloon with the liquid, and we do not inflate the balloon prematurely. It was only for a single inflation, and the balloon size was pre-specified to be 1.0 to 1.1:1 to the reference vessel diameter or stent size. And the inflation time was a minimum of 30 seconds, though we recommend until a period of 60 seconds. And the balloon had to cover 2 to 3 mm to the distal stent edge or distal to the lesion edge, and it has to be longer than the pre-dilated segment. A maximum of 2 devices was allowed for each lesion. And a minimum DAPT of 1 month was recommended. This was the first case that was recruited, and it was recruited to the sirolimus-coated balloon. And you can see a severe proximal LED DES ISR, and this was treated, and that was the results post-procedure, and this was the results at 6 months angiographic follow-up. The first patient was recruited in December of 2015, and the last patient was in January of 2017. And the completion of 6 months angiographic follow-up was in July 2017. The patient characteristics between both arms were no different. And what is interesting is that diabetes was in 3 out of 4 patients, and 1/3 of patients were on insulin. There was also no difference with regards to the procedural data. the length or diameter of the previously implanted stents, the number of study balloons, the balloon pressure, and also balloon inflation time. We studied the QCA per protocol analysis. Once again, if you to look at the difference between both groups, there was no difference in MLD pre-PCI for both in segment and in lesion and diameter stenosis. There was also no difference in the MLD in the final in segment and in lesion between those two groups, and also no difference with regards to the diameter stenosis and acute gain. The follow-up was about 180 days or 6 months. And once again, there was no difference with regards to the mean luminal diameter follow-up in lesion and in segment. The primary endpoint of late lumen loss was also no different between both arms of 0.25 and 0.28 in the SCB and also the Paclitaxel coated balloon. The intention to treat group, or rather the intention to treat analysis, was also showing no difference statistically from both arms, though it was interesting to note that it seems to favor the sirolimus coated balloon versus the Paclitaxel coated balloon with regards to late lumen loss in lesion of 0.26 versus 0.37 and 0.18 versus 0.31. But really, this is statistically not significant. The clinical follow-up at 12 months, and this is interesting because there was no difference in TLR, no difference in stent thrombosis or death, and MACE in the SeQuent Paclitaxel DCB was 16% and 12% in the sirolimus coated balloon. Statistically, no different. To summarize, or rather to conclude, the first in men sirolimus coated balloon versus Paclitaxel DCB in the treatment of DS-ISR. Both products appeared to be safe and effective, and technical success rate was high in both groups. The late lumen loss was similar at 6 months between both groups, and this actually proves the study analysis or study design of being non-inferior to Paclitaxel drug-coated balloon. There was also similar secondary endpoints between those two groups. And I would like to thank you for the kind attention, and we'll go over to Bruno Scheller, who will then present the trial that will be ongoing in the US. And over to you, Bruno.
My name is Bruno Scheller from Saarland University in Germany. It's a great pleasure for me to report you on the clinical trial design of the RESPECT-ISR US IDE trial. This is my conflict of interest related to this presentation. We started clinical research with Paclitaxel-coated balloons end of the year 2003 with the Paclitaxel-ISR trial. In this trial, we could demonstrate for the first time that treating in-stent restenosis with Paclitaxel-coated balloon leads to a highly significant reduction of neointimal formation compared to conventional balloon angioplasty. And this angiographic benefit is reflected in a long-lasting clinical benefit in terms of reduction of repeated reinterventions of up to 6 years. Meanwhile, a large number of randomized trials comparing Paclitaxel-coated balloons with alternative treatments, in most cases drug-eluting stents, in the treatment of coronary artery disease, including in-stent restenosis and de novo disease. In this recent meta-analysis published by an international author group last year shows in 4,590 patients in the first year lower risk for myocardial infarction when using Paclitaxel-coated balloons, and at 3 years and beyond, a lower all-cause mortality, mainly driven by reduction in cardiac mortality. The Daedalus patient-level meta-analysis focuses on the randomized trials comparing Paclitaxel-coated balloons with drug-eluting stents for the treatment of in-stent restenosis. And as you can see, there was some advantage for the stent-in-stent approach in terms of reduction of repeated revascularization. However, if you look at the hard endpoints, death or myocardial infarction, there was a trend for a lower event rate when using the balloon approach compared to the stand-in-stand approach. And these data altogether support the recommendation in the European guidelines for revascularization. We have 1A recommendation for the use of a drug-eluting stent for the treatment of instant restenosis, or at the same level of evidence and a recommendation, the use of a paclitaxel-coated balloon. What is the situation in the United States? This paper shows you the numbers of coronary interventions in the US dedicated to the treatment of instant restenosis. And interestingly, this reflects about 11% of all procedures. And this number has been very stable over the years, despite the fact that the use of the metal stents decreased and we have better newer generation drug-eluting stents. The treatment in the United States is about 70% stent-in-stent, which is, however, an off-label approach there. And therefore, we see also brachytherapy and even conventional balloon angioplasty as primary treatment for instant restenosis. Therefore, there is an unmet clinical need in the United States due to the fact that there is no coronary drug-coated balloon available. So the RESPECT-ISR trial is a prospective randomized multi-center trial. It will compare the SeQuent Rex paclitaxel-coated balloon with conventional balloon angioplasty in coronary instant restenosis. It is a superiority trial with 2-to-1 randomization, DCB versus POBA. The primary endpoint is target lesion failure at 12 months. And in addition, the first 100 patients will undergo angiographic follow-up. In total, 296 patients will be included at 30 sites in the United States and Central Europe. The inclusion criteria require a significant instant restenosis with ischemia. It is allowed to treat up to 2 instant restenosis lesions within this trial with reference diameter between 2.5 and 4.0 millimeter, and a total lesion length, each of 34 millimeters, to permit treatment with balloon of up to 40 millimeters in length. The primary endpoint, freedom from target lesion failure, at 12 months consists of clinically driven target lesion revascularization, myocardial infarction, as well as cardiovascular death. The major secondary endpoint for the 100 patients undergoing control angiography will be late lumen loss assessed by a QCA. Eligible patients will first undergo lesion preparation, and after lesion preparation, according to the DCB consensus group recommendations, will be evaluated if it's an acceptable result of lesion preparation. This means no flow-limiting dissection, type A and B dissections are allowed, and a residual stenosis of less than 30%. If these criteria are not fulfilled, the patient will go to the registry arm and will be treated with drug-eluting stent. If the criteria are fulfilled, the patient will be randomized to the SeQuent Rex DCB or POBA in a 2-to-1 fashion. So my conclusion is that instant restenosis represents about 10% of all PCI procedures in the United States, stable over the years. Outside US, stand-in-stent or paclitaxel-coated balloons are standard of care with a 1A recommendation in the ESC guidelines. Current treatment in the US consists of POBA, brachytherapy, or stand-in-stent. And the RESPECT-ISR trial aims to investigate the safety and efficacy of the SeQuent Rex DCB to support an FDA pre-market application. And the investigational device that will be used is the SeQuent Rex, a next-generation paclitaxel-coated DCB based on the SeQuent Neo DCB, which is available outside the US and have a very large clinical database. However, this new DCB will use resveratrol as excipient instead of iobromide. Thank you very much.
Thank you very much. So there you are, ladies and gentlemen. You have heard 4 lectures or presentations on drug-coated balloon involving both PCB and also as sirolimus-coated balloon. I would like to encourage the attendees to try and go through the chat and ask for questions, and Professor Scheller will try to answer all of them. And in the meantime, we're going to just have a discussion among ourselves, and I hope you'll be able to listen in and also to contribute in some ways. So, the uptake of DCB is still rather small because of the presence of DES, and people are so comfortable with using stents, and the results have been so good. So I just would like to pose this question to both you, Raban and Sylvia. Firstly, you to Raban, in terms of what is the usage of DCB in your clinical practice, and what sort of clinical subsets are you using DCB right now? Raban?
Yes, thank you, Rosli. I think it's a very important point that we really focus on specific groups of patients. I think although we did a lot of DCB in the last years, there are lots of interventionalists, even in my hospital, that are not really comfortable with DCB. Most people say that they cannot be sure of the results. They cannot be sure that the patient has a problem when he's on the ward or at home even. And I think it's really important to stress the point that we have really good data that support that DCB are safe. In the basket small 2 trial, for example, we didn't have one case of acute vessel closure. And therefore, we are really happy that we have quite a lot of DCB interventions in my clinic. I think the 2 main or the 3 main indications are the instant wrist stenosis. In this kind is almost 100% DCB use. Then we have a lot of small vessels in diabetic patients, for example, or patients with renal failure, dialysis patients. I think this is really a good indication. And the third big part are the bifurcations, where we really try to use the DCB in the side arms. Mostly we put the stent in the main branch, but in the side branches we try to use the DCB as often as possible.
Yeah, Sylvia, what about you?
Yes, I agree with Raban in every aspect he just mentioned. I think the problem with using drug-coated balloons is that it does require some operator experience, and of course it usually maybe takes a little longer than just go fast, put a stent in, you have a nice angiographic initial result, and everybody is sure. With DCB, you need that experience to judge dissections that you can leave behind without worrying, but you have to go through this learning curve to see that it's possible and that it works. So it's highly dependent on the operator and highly dependent, I think, the percentage of usage on the center. I'm traditionally coming from a center due to my former colleague, Dr. Perner, that we have always used a lot of drug-coated balloons. And quite frankly, I always think about the usage of a drug-coated balloon in every intervention except for left main as a possible device. But of course, as Raban said, the main indications are instant wrist stenosis. We use almost always a drug-coated balloon there, small vessel disease, but even there, I am somebody who goes for like larger sizes. I actually didn't even want to have balloons smaller than 2.5 for the new SCORE registry in our lab. And bifurcation is an important indication. I always try to do a single stent strategy because I do think it's better especially in bifurcation, to have less metal, leave less metal behind. And yes, and the rest is highly dependent on the operator. I think for patients with multi-vessel disease that are younger, that are not going to bypass surgery, I do think it is a feasible option to treat some of the lesions with drug-coated balloon, because you do not know how atherosclerosis, coronary artery disease develops the next few years, and you still have the option to do everything with that coronary. But of course, if you have just a type A lesion, a short lesion, proximal lesion, then there's no need to really go for a drug-coated balloon. Then you have, if you put in a big stent, we also know today the data is good that you have a very small percentage of target lesion failure.
Yeah. So, I mean, if I were to extend the question to you, Sylvia, in terms of your advice with people who want to, utilize DCB, what are the important steps? Do you, for example, what is a ratio of the device in terms of vessel preparation to the vessel to device to a vessel ratio? And do you tend to suggest that you should use scoring balloon in all your patients, or just normal regular balloons?
I think you should need to focus that you need to use big enough balloons for lesion preparation, and that you even go beyond the 1.0 lesion to reference diameter ratio. We personally work more with 1.2, maybe even higher. I don't agree with the consensus paper that is a little more conservative at this aspect. And you can even use non-compliant balloons. I personally don't use scoring balloons that much, except for instant restenosis. There, I think it's a given, it's good. For the novo stenosis, I don't think it makes a big difference, but maybe other people have different experience. Yeah. And I think also for the predilation, you need to have a long enough inflation time. Don't just do it for 10 seconds, go for even there for 30 seconds or even longer. Yes, those are
useful. Raban, what about
predilation or preparation is good.
Do you do it the same way in terms of vessel preparation, or is anything different?
No, actually I'm doing the same. I think it's really important as a shift in thinking that you really have a good result before you deploy the DCB. We all know the discussions in the consensus papers and in all these conferences. Lesion preparation is key. And when you have a good result, then you can deploy your balloon as a carrier of the drug. However, the lesion preparation, we always try to make it as simple as possible. I always start with a regular balloon, and if the result is acceptable, which is the case in almost 60 or 80%, then you can directly go to the DCB. However, when the result is not good, then we escalate to non-compliant balloons or scoring balloons. But having said that, it's clear that one of the disadvantages of the technique is that you need more time, you need more equipment, you need more money. And I think this is really one point that we should discuss. I don't know what others think, but I think this manner of preparing is some financial disadvantage in the whole thing.
Yeah. But as both of you mentioned, what is key is vessel preparation, and this is where if it's not like we are putting in a stand where there's a scaffold, you can inflate and you get results. But with balloon, we are falling back to what we were practicing in the past, and you may not get as beautiful results as with stents. But in the end, if the results are good and with the data showing that the risk of acute or abrupt occlusion is going to be small, and in the long term, the vessel will heal and you allow the vessel to come back and function normally. And there is a 70% chance, as shown in papers previously, that the vessel can at least enlarge. So leaving nothing behind is, I think something very attractive. One just needs to be a bit more patient with it. I think you will probably agree with it. We we're discussing about sirolimus coated balloon. Obviously, this is something of interest. Where does sirolimus coated balloon stand in your practice right now? Because there is not much of data. Do you think that at this point, do we have got commercially available SCB, whether it can be used comfortably, interchangeably with PCB in these lesion subsets that you treat? What do you think, Sylvia?
Well, I think I've shown you the overview. We do need more data right now. And I mean, we have a large evidence for paclitaxel coated balloons. So it doesn't, it's not really the time to just change the practice from paclitaxel coated balloons to sirolimus coated balloons. I do think we need to get the data, we need to get the evidence. And if you use sirolimus coated balloons at this time point, they should be included in some kind of trial registry. And so that we generate evidence.
And is that the same with you? Are we going to be cautious as it is at this point in time, Raban?
I couldn't agree more with Sylvia. I think we need more data. However, I'm not a fundamentalist. I think both drugs could be good for the patient. Paclitaxel could have some advantage regarding the positive remodeling on the long run, which sirolimus might not have. I'm not sure. I'm totally relying on the data. However, I think it's good to have several options. I think it's good that DCB strategy will have several options with several drugs coating, and I think this will help the whole technique.
Yeah. Sylvia, with the, yes.
Just one aspect to mention from my side, with my small experience so far with the sirolimus coated balloon, what I noticed is that the balloon itself, or the product itself, has a larger flexibility and a higher deliverability compared to paclitaxel coated balloons, so this might be an advantage, but of course we still have to see. And as Raban said, I think it's like how it is with the drug-eluting stents. It's nice to have a bigger portfolio, and we need to see at the end, after we have clear study data available, what are advantages, disadvantages, or maybe even the indications. And I think I will look at the data for de novo stenosis and instant restenosis. I have no idea, but maybe at the end we will have different products for different stenosis types. I don't know.
Yeah. Now, if I were to come back to what we are currently using, which is with the paclitaxel coated balloons, do you think it's enough? We have got enough data right now, or rather enough experience to actually expand it beyond what is being suggested, recommended, especially in the de novo lesions, whereby stents will probably be good. So outside the small vessels, in a non-small vessel, do you think it would be quite appropriate for us to try to practice using DCB, Raban?
Yes, definitely. I think this border of small to not so small is really a gray zone, and we're using the drug-coated balloons in even larger vessels than 3.0. So we're really feeling comfortable with it. I think it depends on the result after pre-dilatation and not so much on the vessel size. However, we have done the trial in small vessels, but I know that some new trials are coming in all-comer patients, and I really look forward for this data.
Yeah. All right. So we are actually moving towards the end of the session, but before we end, and before I give my concluding remarks, are there any advice that you'd like to give to our attendees with regards to using DCB? Raban, let's start with you first.
I think just try it. Try to use DCB. I think there's a good chance that you get away without the stent. And if it's not working, then you still have the stents. It's a good method, and the two methods are complementary. And so just try it.
Yeah, good advice. Sylvia, what about you?
Same from me. I think you just need to overcome your internal hurdle of accepting a non-stent-like result in the angio, and to give a little bit more love and time in treating the patient than just doing something fast and easy.
I think those are wise words from both of you. So it gives me my great pleasure to actually summarize, say some concluding remarks on the session that we are having. Firstly, what we had was we've had a series of presentations. We actually had a look and a review of paclitaxel coated balloon, and this was done by Professor Jeger. He emphasized that there are meta-analyses that has been conducted comparing paclitaxel coated balloon with alternative therapy, and this includes POBA, DES, and also BMS. And the long-term efficacy and safety was actually proven, and at least in that meta-analysis, it favored the paclitaxel coated balloon in the long term. The emphasis of the concern of DCB with regards to mortality was apparently shown in the treatment for peripheral vascular disease, even though there are lots of limitations in that study. But really, there is no increased risk of mortality that has been seen in patients treated with DCB in patients with coronary artery disease. So at least be assured that there is no increased mortality and the benefits are still there. Bruno also touched on the prospective, or rather the RESPECT-ISR investigational device exemption trial, and hopefully this will actually help to get the CE mark for the use of DCB in US, where they have not been able to receive or rather to accept or use the device that is now currently being used worldwide, especially for in-stent restenosis, which is a type A, 1A indication. We also, the two speakers also discussed, and I also showed our use of sirolimus coated balloon, the first in men for the SISR, and also the large SCORE registry that is ongoing. Dr. Sylvia just shared with me that she recruited a 6th patient just now. So hopefully we'll get to see the use of SCB in a large all-comers trial and see the use and benefits of SCB or sirolimus coated balloon in the future. We also discussed a bit the concerns of utilization of sirolimus coated balloon with the current data that is made available, and just a bit of caution because we don't have enough data to actually say just because SCB is there, it can replace paclitaxel coated balloon in the subset of patients' lesions that we use right now. So a matter of a word of caution with it, we just need to have more data before we can actually embark freely on the use of drug-coated balloon. I hope, ladies and gentlemen, you have gained further insight in the treatment of coronary disease using both therapies, the paclitaxel coated balloon, and of course the sirolimus coated balloon, which is still in its infancy with regards to data and trials. I would, as both speakers, encourage you to consider DCB in your practice, because if you just need to have a bit more patience, and when you properly prepare the vessel very well, you find that your results will be much better. Remember, DCB is only to deliver the drug and not to prepare the vessel. So prepare the vessel very well. When you have a vessel which is well prepared, as being suggested, less than 30% residual stenosis, no dissection which is flow limiting, then you can use DCB, and you find that you feel encouraged and comforted that once you get good results, and at least with every experience, with every confidence, it will then propel you to try to use and think about using DCB much further. Because in the end, what is attractive is that you leave nothing behind. I would like to thank the speakers for their kind presentation. Obviously, the chat master, Bruno, I wished he was also here with us. And B. Braun for this, for sponsoring this, and to EuroPCR. So I hope to see you all again in future. Thank you very much.